behalf of the American Heart Association, I would like to welcome you to this session, Spotlight on Admission, Models for Identifying HFpEF and HFmrEF at Admission. Timely identification of heart failure with preserved and mildly reduced ejection fraction at hospital admission is crucial for initiating appropriate care and improving outcomes. This session explores how hospitals are addressing the challenges of identification of patients upon admission. Throughout this session, you will have the opportunity to submit text questions for our speakers using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during the Q&A at the end of the session as time allows. To access live closed captions, please click on the closed caption button found on your screen. All sessions will be recorded and available in the coming weeks. It is my pleasure to welcome our first speaker to this session, Dr. Hassan Alloway from University of Alabama, Birmingham, where he serves as the director of UAB's Cardio Hospitalist Service. As a reminder, full speaker bios can be found in the event lobby. Dr. Alloway, the floor is yours.
Thank you, Jennifer. Hey everyone, so we're gonna just show a case how we're identifying patients who come through the emergency with heart failure basically, and HFpEF and HFmrEF included. Notable that we're looking at patients who come into the hospital service or cardiology hospital service, mostly because patients who are admitted to the cardiology service are easy to identify, and the numbers are probably a bit smaller, and the pathway for these patients is probably straightforward, but we do not want to miss patients, so that's why we're going through this process. So what we went through first of all, the platform that we use is Cerner voice AI pager system for our pager. The target for every single patient gets admitted to the hospital with heart failure. This is the target. What we're trying to build is a cardio hospital service unit, and we try to cohort patients. This is the primary target for us. Try to get these patients to this unit in specific, and then try to utilize all the proper treatments, follow-ups, support from medication standpoint, or social work, or all it comes. Of course, look at opportunities for improvement, insurance status and stuff. We hired a coordinator specific for heart failure patients to help implement this, especially prior to discharge, a discharge process, to make sure everything is in line and have all the appointments coming up and all the follow-ups coming up. The outcome that we were hoping for was mainly to reduce readmission rates, like in general, and hopefully even more later on. But this was the primary outcome. We started this process around, like, I would say, 1.5 or 2 years ago, and we've been successful so far. So we started with a screener study to look at what would be the best identifier of patients who come in through the emergency with heart failure, and this is including any heart failure to the emergency. So we tried. These are the main stuff we have. We have a power plan that we use, and there's an incentive for providers to use the power plan, and in our hospital, it's like part of their incentives is using the power plan on every heart failure patient. So in general, it's being utilized a whole lot. This has a lot of medications and weights and ins and outs and stuff specific for heart failure admissions. So this was the first identifier. We noticed that sometimes providers do not identify patients with heart failure on admission. We still miss some patients, especially if they're not known to have heart failure, if they are known to have COPD before, and there's a suspicion, they do not utilize the power plan. So we wanted more identifiers. So we tried to use IV Lasix use in the emergency prior to admission. So this was the screener study, and we used the diuretic use, either IV Lasix or Bumex in the emergency, and or the heart failure power plan used, and that's for patients admitted to the hospitalist cardio-hospital service or the general hospital service. And then afterwards, we would screen these patients to see if, for example, they were like liver patients, renal patients, not really heart failure, and screen them out or screen them in. So we get an auto consult on all of these patients. So what we found is mostly, this is just to show the power plan, but what we found is mostly we are not really missing any. Like you can see, we can identify like almost 90% is positive, predictive kind of for patients, mainly for the IV diuretic use, and that power plan would not would be very positive, but you would miss some again for patients who are not identified emergency. But the IV Lasix or the BMX emergency would be like on top screener, and that was positive for us. This is what the power plan looks for us, mainly for vital signs, pulse ox, weights, arrhythmias, and the education part for heart failure. Referral to the cardiopulmonary rehab is included, nutrition, of course, and the last one is the one that fires up the consult for us and the coordinator to like look into and add this patient to the list and start the process. This is the one that we usually start the process with, the cardio hospitalist rule, which is a fire of a consult pager through the Vothera system. And this is again what we found, like, these are patients who are, we have heart failure, power plan used or no, with who have acute heart failure, do not have acute heart failure. As you can see, with the power plan, you can miss some. You can have like some patients who do not even have heart failure, but they just use the power plan just in case. But if you use both Lasix and Bumix, you're basically not missing any more patients at all. This was basically the main addition that we had. In the screener, I think we had more than like 99% of the patients identified then, or 95%, and we got even more later on with more reinforcement to the providers to use more the power plan. Lately we've been seeing like very less identifiers through the Lasix actually, and even less than what you're seeing right now. This was an over a couple of months. It's more of the heart failure power plan used right now. In general, this is what we look at. This is the sheet that we get all the patients included in. The location is mainly what we look at first, and then of course we include the EF. Is the power plan used or not? As you can see, it's mostly used in almost all patients. And then we start the implementing everything for outcomes. So we add on if they have a payer, if there is a cardiology consult included, if there is a readmission, if this was a readmission or not. This is education readmit. As you can see, these are just happens to be none of them are readmitted, but the education part is mandatory right now, and the follow-up appointment is requested, and yes, is solid that we have the appointment in hand before discharge. So everything is being requested before discharge. This is what really was the main outcome that we got after a couple of months of using this power plan. CTC for us is the location. There's a cardiology transition clinic. This is the main follow-up for our heart failure patients after discharge, within 7 days of discharge. And this is what we saw. This is a trend to improvement, and we actually have better outcomes, but it's not as solid. But we just wanted to showcase for over a year what we found is the reduction in the readmission rate, related and non-related. As you can see, there's a significant trend towards less readmissions at 30 days. Lately, we actually got more data, and we're seeing even more single-digit readmission rate under the cardio hospital service, a bit more under the hospital service. But again, these patients might be more really like very sick HFpEF patients that would get more. But we've been seeing like a single-digit readmission rate if we do all of these measures. I think the big movement for us is going to be EPIC, and the next step, are we going to lose any of, let me just, sorry, go backwards. If we're going to lose any of this, because we were talking offline, some of these steps are going to be missed, including the IV Lasix identifier, IV BMX identifier. So we're going to learn more from our colleagues right here.
Thank you, Dr. Alloway, for your presentation. As a reminder to our audience, please send in your questions at any time, and we'll review the questions during the Q&A at the end of the session. It is now my pleasure to welcome our next speakers for this session. Marichelle Flores, RN from JFK University Hospital in Edison, New Jersey, where she serves as the Quality Assurance Coordinator for heart failure. Presenting alongside her is Josephine Storch, also from JFK University Hospital, who serves as their Director of Cardiology, Business Analytics, and Quality. Marichelle and Josephine, the floor is yours.
Thank you. Good morning, everyone. My name is Marichelle Flores. I'm the Quality Assurance Coordinator for Heart Failure here at JFK University Medical Center.
And I'm Josephine Storch, as Jennifer just said, Director of Cardiology, Business Analytics, and Quality.
We first would like to extend our gratitude to AHA for the opportunity to present our communication tool design to improve heart failure data collection through real-time abstraction, leveraging teamwork and effective communication. This tool has been instrumental in helping our team identify patients with heart failure, plan suitable treatments, and address their social needs. Before we dive into our presentation, I would like to provide some background information about the hospital we represent. JFK is part of the Hackensack Meridian Health, the largest comprehensive healthcare network in New Jersey. JFK is one of its 3 academic medical centers. We are located in Edison, New Jersey, and we cater to 3 central New Jersey counties. As a 498-bed nonprofit acute care academic medical center, we also serve as a significant teaching institution. Our mission is to deliver advanced, patient-centered care while acting as a global hub for medical innovation and training. Among our various distinctions and recognition awards, we have received AHA Get With the Guidelines Heart Failure Gold Plus Award for 3 consecutive years. I would like to share a little bit about where we started and how we approach improving our heart failure performance metrics. Our hospital cares for approximately 1,400 patients with heart failure each year. Our initial program model included 1 advanced practice nurse, 1 navigator, and a third-party data abstraction service. Due to the high volume of patients and limited staff, we face challenges in meeting key AHA Get With the Guidelines heart failure performance metrics. In the summer of 2022, a new multidisciplinary team was established under fresh leadership. This team is led by Director of Cardiology, APP, and is comprised of 3 dedicated heart failure APNs who identify heart failure patients upon admission and follow up their progress throughout their hospitalization. They conduct daily rounds to ensure adherence to guideline-driven medical care. We also have expanded our navigator team to include 2 registered nurses. They round on our heart failure patients, addressing social determinants of health, scheduling a 7-day follow-up appointment, and establishing rapport with patients for post-discharge calls. Additionally, we have brought in a dedicated in-house data abstractor to facilitate real-time monitoring of heart failure patients, aiming to prevent metric fallouts before the patient is discharged. Although the growth in personnel enhanced our heart failure program, it also introduced new challenges in coordinating care and communication among various disciplinary roles. This resulted in the creation of a centralized communication tool to facilitate collaboration and ensure the consistent attainment of heart failure quality metrics. I will now hand it over to Josephine to elaborate on real-time communication tool.
Thank you, Marichelle. So this slide highlights milestones in the evolution of the tool. So first, in collaboration with our key stakeholders, we transitioned from a single spreadsheet to a shared Google Sheet. And that was organized by monthly tabs, and it included some basic key patient level data points. Oops, wrong button. There we go. As time went on, we realized we needed more information to help us attack and reduce readmission rates. So we expanded the tool to track critical follow-up metrics. We added columns for 7-day follow-up appointments and also the patient's assigned cardiologist or PCP. So now we started getting greedy. We wanted more data, so we focused on integrating guideline-driven care into the tool. We added columns for flu and pneumonia vaccines, nursing metrics, ejection fraction, and heart failure discharge medications. Our most recent evolution moved us from spreadsheet to Smart Tool. We reduced monthly cleanup for the data entry errors by adding drop-down menus to ensure discrete, accurate data entry, and we provided real-time compliance monitoring by adding real-time analytics to each monthly tab for immediate identification of care gaps and also successes. So we transformed our tool into a dynamic table with advanced functionality. So our current shared tool has 46 data columns. Don't let that scare you. In the next few slides, we're going to highlight a few key fields that enhance team collaboration and support best practices and metric compliance. So first, these two columns, message to the NP and NP response. So these two columns allow for back and forth communication between Marichelle, our heart failure quality assurance coordinator, and the clinical team. They address gaps on documentation or care concerns and provide that communication back and forth. Next, another column we wanted to highlight was the last REDS. So at JFK, we've adopted the REDS technology to enhance the evaluation and monitoring of our heart failure patients. The REDS, or Remote Dielectric Sensing Device, is a non-invasive wearable vest that uses electromagnetic technology to accurately measure fluid accumulation in the lungs. And this helps our clinicians adjust treatment and significantly reduces that premature hospital discharges. So in turn, reduces that heart failure to heart failure readmission rate. So having access to this, or their last value before discharge, allows the APPs during clinic visits post-discharge to be able to compare easily to the readings they're getting in that visit. And that sends me to the information here in these columns, which is all about the post-discharge follow-up information. So this gives all the physicians' names, date and times, and allows our APPs and navigators to be able to effectively plan that post-discharge care. So as we move to the right inside our tool, we are ending up on columns that, as you can see, where we added ejection fraction. So this puts this right in everyone's face. They can see what that ejection fraction is, and then it helps us identify those heart failure populations. It allows for analytics as well as just knowing what that was during their admission. Next is, and here we're highlighting discharge medications as well as the drop downs. One of the key takeaways for the drop downs that have been created, as well as all of the drop downs that have been created for the other fields, is that it's an agile process. We can, whenever we need to, either dive deeper into an answer or break things apart. We can change our drop down menus. So in the example I wanted to give is you can see answers for CI or contraindication. Well, we needed a little bit more information on some of our patients, like was the contraindication a medical or insurance, which we were finding with some of the medications. So we added another drop down, which allowed us to dive deeper into those care gaps. This slide represents the calculation section of the tool. It's managing our nurse-driven metrics and our discharge metrics, as well as a separate metric that helps us figure out whether or not the APP has addressed the compliance or medications. So that basically showing that that APP has documented and assessed the patient. Each monthly tab has this 15-row section below all of the abstracted data. So it's continuously updating as data is entered. So as Marichelle enters, the calculations update, and this provides our heart failure teams with immediate access to compliance metrics that support inpatient and post-discharge care. This proactive approach allows us to tailor our 30-day follow-up care, reducing readmissions as we help our patients understand and live with heart failure. So now I'm going to hand it back to Marichelle so she can share with you her daily workflow.
Thank you. So the real-time communication tool is monitored daily by the Quality Assurance Coordinator, which is me. Our heart failure patients are identified by our advanced practice nurse team each morning based on the admissions from the previous day. Then they are recorded in the spreadsheet, and I subsequently monitor for the latest EF, ejection fracture, and the REDS reading. So based on the cardiologist's documentation, plan of care, recommendation, the APN notes, and any diagnostics that have been ordered and completed, we will keep an eye on the treatments that need to be initiated during their hospital stay, which includes medication or any additional diagnostic tests. The APN will also use EPIC, which is our EMR, to communicate potential discharges for the day. I will then refer to the real-time communication tool to review the medications that the patient will be prescribed and ensure a follow-up appointment has been scheduled within the 7 days. If any criteria for potential discharges are not satisfied, I will then communicate via a shared Google Sheet or Google Chat space, tagging the relevant team member who needs to address any deficiencies before a patient leaves our facility. The outcomes from our newly established team structure and real-time quality tool has led to a nationally acknowledged measurable enhancement in patient care. As you can see in our baseline compliance back in January of 2022, we were below a national average of 57.7%. Fast forward to 2025, we have a year-to-date of compliance of 97.9%, with 7 out of the 10 months at 100%.
So in conclusion, as Marichelle just discussed, our shared tool solved critical communication gaps, directly improving our team's ability to meet quality metrics and address our patients' needs efficiently. We also had a system-wide impact after sharing our PI project with our leadership at Hackensack Meridian Health, and our tool became the inspiration for a network-wide heart failure dashboard. And just like the rest of you, our journey is ongoing. The complexity of our heart failure patient population requires all of us to constantly think outside the box, driving improvement in our outcomes and workflows. Who knows where this tool is going to be in the future? But most importantly, I am proud of our heart failure team here at JFK for embracing the vision and core values of Hackensack Meridian Health's 5 C's. Because in order for this project to succeed, we needed to be creative to make things better. We needed to be courageous to do the right thing, be compassionate and remember that human experience, be collaborative and embrace teamwork, and be connected and be part of something bigger. And as I always say, teamwork does make the dream work. So thank you all for your time and attention.
Thank you, Marichelle and Josephine, for your presentation. A reminder to our audience to go ahead and submit your text questions for our speakers using the questions feature on your control panel, and we will address them at the end of our presentations. It is now my pleasure to welcome our last speaker to this session, Lanny Nelson from Carteret Healthcare in Morehead City, North Carolina, where she has served as a respiratory therapist for the last 6 years as a quality specialist. Lanny, the floor is yours.
Yes, hello. Get onto my slide here. Thank you, Jennifer. I'm from Carteret Healthcare. We are a 135-bed community hospital in Morehead City, North Carolina. We're out on the coast. We are the first stop for about an hour for a large portion of our community. So we have a full range of acute care, diagnostic, and outpatient services for our HFpEF and HFmrEF patients at admission. That all starts in the ED with the ED physician recognition of heart failure. They will start with an admission bed request, and then the hospitalist is consulted. At that point, the hospitalist will go down to the ED to admit that patient. ideally they will use the heart failure order set. We use Meditech at our hospital. So that's been built to include consults for a variety of the team members that need to be included in the patient's care. That will include a cardiac rehab referral, a dietary consult, a pharmacy consult, and then the transitional care consult are all pre-checked on that order set. Our transitional care team is a group of nurses that focus on our heavy hitters for readmission risk. So our heart failure patients, COPD patients, pneumonia patients, disease processes like that. So that will get that process started for them to get a referral for that patient. At that point, they'll get upstairs. The transitional team has 2 ways of identifying these patients. So again, with the consults, nursing can also order a consult for the transitional care team to see the patient if that order set wasn't used. We were still finding, though, that we were missing some people. We weren't catching everybody at admission from those consults. So maybe it was a case where the heart failure was a secondary diagnosis or it wasn't immediately recognized. So to catch those patients, the transitions team had a Meditech report built that collects patients with an elevated BNP. That was after some collaboration with our cardiologists and hospitalists of how to kind of cast a wider net to catch more of these patients. Those patients are daily added to a spreadsheet that the transitional care team reviews further to determine if that elevated BNP, they actually do have heart failure, and then maybe it's just not being addressed or documented appropriately. This is a lot of these things are happening kind of simultaneously as the patient's getting admitted. Like I said, nursing can also enter that transitional care consult. Then they will begin to personalize the patient's care plan. As they're going through that, they'll add heart failure to the problem list. That will populate a variety of additional interventions and education requirements for that patient. So it will prompt them to document if they have the left ventricular function evaluation. So do we have a recent echo or has one been ordered on admission so that we can get an accurate EF on that patient? It will go ahead and prompt them to provide the patient's education packet and any of the education that we'll be sending home with them. We go ahead and give them at admission so it can be reviewed with staff one-on-one and not just given to them at discharge. And then it will also prompt our education process to start with that patient, which is done in phases by our nursing staff. The first phase will start on admission as soon as that's added to the care plan. And then depending on the patient's education and comprehension levels, they will continue through the phases to make sure we get that 60 minutes of education at least with that patient. It will also allow for if there's a new nurse the next day can look back and see, okay, this patient didn't quite understand this part of the process. Let's drill down on this and go over this again with them, just to kind of help make sure they understand, especially if it's a new diagnosis for the patient, make sure they understand the care that's going to be needed and what's going on with their health. They also ask at this point if they have a scale at home so they can continue their daily weights. And do they have a blood pressure cuff at home so they continue that? And then we'll give them the logs so that they can keep track of that at home and continue to take those to their doctor's appointments and follow-ups. And then also that would be available for them when the transitional care team would call them after discharge and go over those logs as well. And then our last set of eyes to try and catch all these patients are the quality concurrent reviews. So our quality department reviews all new patients daily. We look for a variety of disease processes and measure compliance for all of our Get With The Guidelines programs, for Joint Commission, for CMS. And with these reviews, we can also kind of see if we're missing a heart failure patient. Maybe it's just not being documented. The documentation needs to be beefed up some, or we can also speak with the providers and the nursing staff to say, I think with this patient might have heart failure, and then to ensure that the appropriate medications are being prescribed, that any documentation is complete and accurate, and then that the patient is getting educated appropriately, and that all the pieces are kind of coming together. So it's all happening kind of within that first day, but we all kind of have to work together and communicate with each other to make sure we're not missing these patients and we're all getting, and then ideally to keep them out of the hospital for our readmission rates. So thank y'all very much.
Thank you so much, Laney, for your presentation. We have a lot of questions in the chat, so we'll see how many we can get through. Just kind of scroll through them. One question we received, and I'll open this up to whoever feels like they could answer this. Some of them I can tell who they're for, and some are a little harder. But does anyone know, can you bill for the coordinator's time?
We have not been for us. I don't think we can, but we have not investigated enough, I guess.
Yeah. Thank you, Dr. Alloway.
I do not know how that is billed for or if it's able to be billed for. I can find out though and give you that answer, but I don't know right now.
Yeah, perfect. Wonderful. One question it looks like is probably for Marichelle and Josephine. Is your extraction process manual or is Epic talking to your Google Doc?
It's all me, manual. I do the chart text every day. As long as they're still in-house, I go through each patient to see what updates, any updated EFs, any medication, and anything like that. So until they are actually discharged, I will follow up with the patient manually, visually in my office and follow up with the patient that way.
It has been looked at or thought of like at the network level to try and figure out how to be able to like mimic this, the tool itself, and how to pull some of those key pieces of information. But as we were kind of talking before this session, if that information is not in key discrete fields in Epic, it is very difficult to pull it into a report. So until we can align that in a sense across a network, because HMH is extremely network focused. So individual things for individual hospitals don't happen. We have to do them across the network, which is good. But it does lengthen the process and buy-in on where things should be documented and how to pull it out. So more to come, like I said, always evolving. So hopefully at some point it can be pulled.
Thank you, Josephine and Marichelle. To add on to that, another question was that they have a similar model and spreadsheet tracker, wanting to know, has your compliance led to a lower readmission rate?
We have definitely reduced heart failure to heart failure readmission. So if we just pull out those, and again, that was that compliance on the medications, the REDS reading, like all of these different initiatives that we've been doing.
Appointments.
Yes, the follow-up appointments has been huge on reducing that readmission rate. We still struggle. We have a very large kidney failure population. So that unfortunately impacts us. And that is just a more complex patient that takes a little bit more than just your heart failure tactics. So yes, the bottom answer, it has made a difference.
I think we can open this up to any presenter. The question is, do you provide heart failure patients with a scale?
We do. We have a grant that was through a university hospital that partly our transitions team and partly our education team applied for and received, that we have a community outreach bus, and that goes around the community to do health screenings, and also provide us some money where we could give them blood pressure cuffs and scales to go home if they don't have one already.
We do as well. We have different services for post-discharge care. We have the ambulatory services who would deliver if the patient cannot have one. We have a service for certain patients with a payer that would be actually connected to our system, and we would monitor on a daily basis whenever they weigh themselves. So we have a couple of manners and ways, but yeah, we definitely do that. It definitely helps a lot.
We also have, we actually have the body port where they're monitoring them remotely. So for those patients that they get signed up for them for the 30 days and they're monitored, and that has helped as well with reducing readmissions. So
They're either given at discharge or when they come to the clinic to follow up. The only patients that do not get it are the ones that go to subacute or long-term care.
Another question we received, and then this would be for you, Josephine and Marichelle. How did you receive buy-in for the shared document?
I guess because it was so hard to get the information before, people were just hungry for a communication tool that would at least let you be where you needed to be, and you could just pull up the spreadsheet. And people could pull it up on their phones, on their iPads, on wherever they were, to be able to see what was going on. So it wasn't difficult for buy-in, just organizing and figuring out what data elements were going to be important enough to put in the spreadsheet. Because obviously we're already at 46 columns, we really don't want to make this so long. So it's just, trying to figure that out. So,
Well, that's why I'm there monitoring it. So I would just poke them and say, I need you to look at this specific column. So they're not going through 46 columns. So it's easier for them that way, that they're focused on what they need to address at that moment.
Just a follow-up comment from one of our audience members related to charging for the heart failure coordinator time. They had indicated that they're a heart failure nurse navigator and they do not bill for their time, but they do enter a charge to document time spent with patient. So just wanted to share that. A lot of great comments from the audience. Very interested in this topic. Okay, here's another question. How do you identify those dialysis patients that miss dialysis and are admitted with volume overload and code out hypertension, heart disease with heart failure / CKD 1 through 4 or 5 as a heart failure patient? I don't know if anybody in particular wants to take that one.
sorry, what was the actual question of what
How
do
do
you do with it?
Yeah, so when that dialysis, a patient who missed dialysis is admitted with fluid overload, with that complicated clinical presentation, how do you identify them?
They always end up in our heart failure bucket, and getting them out of there is impossible, honestly. It's very difficult. I think we try with coding and documentation, even being very specific about that.
They actually have to write that it's not an acute heart failure exacerbation or things like that. It's basically documentation of their kidney failure, their missed dialysis, and so it's basically documentation.
And making sure that that's in the discharge summary. Otherwise, coding is stuck with their rules.
Our APNs, if it does fall in our bucket, they will try to reach out to the physician, to the attending, to the cardiologist, even nephrologist, to see if they could change some documentation to see if it can get recoded, because it is truly not heart failure. So they do reach out and try to get it recoded, but like I said, it all depends on the documentation.
Another question is, what is the REDS vest?
Yeah, it's a fantastic vest. It's basically just, in a sense, it's you can't see me, I'm talking with my hands. They just put it on. We actually have someone that goes around and puts it on every single one of our heart failure identified patients at the beginning when they come in, to see, is it true heart failure? It's an impedance. It is It is just measuring the fluid in the lungs. You're really directly, they may have pedal edema, but if there's no fluid in the lungs, then we're not talking about heart failure, so it really helps in treatment. They do this. Certain patients get reds every single day, especially if treatment is either symptoms are still persisting and, whether they need to increase and try different therapies. And then we definitely do it on, say, like the planned discharge day, because that's been a huge help in figuring out if that patient is still wet. If they're still wet, then they shouldn't go home. Even if the patient's like, I want to go, then they're either having to sign out AMA or let us treat you a little bit more because you obviously still have fluid. So it's a very easy way to test if your treatment is working. And if you can Google it to get some pictures of it. It's R small e DS, and it's the I don't know how else to explain it. Hopefully that's enough to get you to take a peek at it. I can always email more information if somebody wants. Yeah.
Absolutely. Another thank you for the great presentations. And then specifically wondering, does the nurse navigator identify heart failure admissions in instances where cardiology hasn't been consulted? So I think we could open that to any one of the presenters.
For us, it was, it's actually, regardless, everybody who gets this power plan ordered or IV Lasix emergency gets to be screened. So, and then, even if they do not have a consult. So for us, it's not the way that we identify patients.
Thank you, Dr. Alloway. And then another question, is the referral for inpatient cardiac rehab phase 1 or outpatient phase 2 referral?
For on our order set, it's the outpatient phase 2.
Thank you, Lanny. And then what is a heart failure daily self-check?
So that's on our nursing care plan. I know it says Q shift now. We're in the process of getting that updated to be daily. It kind of just got into a bucket when it was built that it came up as Q shift, but it's to getting the patient in the habit of doing their self-check at home, checking their blood pressure, checking their weight every day, kind of seeing how they're feeling. Are you short of breath? Were you tired today when you woke up? Those kinds of things. They'll go ahead and start that on admission of kind of prompting the patient with those questions.
Thank you, Lanny.
Oh, I got to check my blood pressure. I haven't done it yet, that kind of stuff. So we found if we kind of get it in their heads at the beginning, then it made them, kind of go ahead and have that in their memory I got to get up and weigh it today. So.
Thank you, Lanny. Question for Marichelle regarding the heart failure volume you have per day, and then just any comment on the resources that you utilize.
So like I said, our APNs or even our nurse navigators will get the list from the day before. So our volume could vary. Sometimes we could have 1 to 2 patients from the night before, or like today, 6 patients showed up. So
Total of like 25 to 30 throughout, right?
like weekly,
Still here.
yeah. And so even though they identify them, that doesn't necessarily mean they're going to end up coding as heart failure. Some of them could be one of our previous patients. So they will show up, and we would we would have them on our lists to either watch, or they would actually be rounded and treated. So it also depends on what their complaint is when they come in. So if we have a heart failure patient, we've had a heart failure patient show up, they might come in for GI symptoms or something not related to heart failure, but we will keep an eye on them.
I guess as far as I was just going to say, I know the question was on resources as well. So you really have, there's currently right now like one dedicated APP that is reviewing any of the new ones, right? And then the others are rounding, following up, and taking care of. So that one is identifying, like you said. So there is one, because one person can't handle it all because they're also seeing in the clinic. So clinic visits are manned by these same three people. It's not, it's one team doing both inpatient and outpatient follow-up.
Thank you, Josephine. Dr. Alloway, I'll target you for this question. The comment is, we're in the process of developing our heart failure team, but for now we have a lot of hospitalists who admit heart failure patients and they don't necessarily consult cardiology. How do you get the buy-in from the hospitalists?
That is not an easy one to answer, to be honest, because when I joined, it used to be not easy because you have to just, I mean, there's a lot of things that you have to incentivize for providers to do things like this, because acute care providers do not usually see the long-term outcomes as in readmissions, or like if you're working in a hospital, or like adjusting medications or follow-ups and stuff, unless you incentivize. So I think the incentive for us for putting the heart failure power plan as a starter was a big move from our end. And then the target was to open a cardio hospitalist unit, and then I got that was my job. That's when I got hired. So I just tried to hire a cardio hospitalist that would help. It's not easy, I understand, but I get there must be some incentive, I believe.
Thank you, Dr. Alloway. And I'll ask one more question to all our speakers today. How did you have to tweak your workflows, your EHR tool, your Google worksheets to monitor specifically HFpEF and HFmrEF patients? Was there any specific interventions you had to do to focus on that population?
We kind of treat both like all the same ourselves. So all these patients who get cohorted into this cohort are being treated almost the same. They get the same appointments, the same follow-ups, the same treatments. Of course, we do not intervene into the specific medications. That's a total different topic. But for the follow-ups, scales, social worker assistance, medication assistance, 7-day follow-up, and whatnot, and cardiology transition, follow-up as well. They have the same process. I think that helped HFpEF more because, if you want to treat them, I believe if you try to treat them different, you might miss on some, because HFrEF takes all the probably like data resource, all the stuff. But if you try to like treat them the same, it might be positive. That's
Thank you, Dr. Alloway.
Yeah, we do the same. We don't really change as far as inpatient. They get the same education and materials and, meeting with providers and consults and all that things, regardless of their ejection fraction. It's just for us, it would change a little bit more on the actual discharge. We have some pieces built to ensure like medication compliance for the less than or equal to 40s.
Great. Well, we will wrap it up. We want to thank all our wonderful presentations by our speakers today and thank our audience for your participation. So many great questions and comments. We appreciate that so much. We'll be launching a poll to evaluate the effectiveness of this session, which has just popped up. It wants me to answer it as well. Oh, shoot. Eddie, you might have to do it one more time. I think when I was trying to get my screen back up, I minimized it. There we go. Sorry about that. But we'll be launching a poll to evaluate the effectiveness of this session, and we truly appreciate you taking the time to share your feedback. Coming up next at 11:55 a.m. Central, we'll have our third session, Putting Evidence into Action, Real-World HFpEF, HFmrEF Treatment Model. Please access this session and return to the lobby using the menu at the top of your screen. From the lobby, click on the Sessions tab first, then click on the individual session to join. We also have a posted link to join directly in the chat that we'll be posting shortly. And we just want to thank you so much for attending today's session. We'll see you shortly in the next session.